I think the interesting thing will be pragmatic clinical trials where you kind of let the clinician explore expectations and then maybe make some suggestions to the patient and that kind of thing versus a more prescriptive kind of approach where you just deliver the treatment. I mean, that's been done to some extent, but really embracing that placebo effect and then, potentially exploring the effect of placebo in physical therapy itself.
Hi, I am Amy McDevitt, and I am going to be interviewing Paul Mintken today for our hands-on, hands-off podcast. So this is our newer AOMT podcast. So I'm really excited to have Paul as a guest. Paul is a professor at Hawaii Pacific University in Hawaii, and we actually had the pleasure of working together for almost 13 years at the University of Colorado. And so Paul has been publishing in the area of manual therapy and orthopedics for many years and is quite well known in the AOMT community. But I'm going to turn it over to Paul to talk a little bit more about himself. And then I want you to just tell our listeners a little bit about yourself and what you like to do and what some of your interests are. So I'm going to hand it over to you, Paul.
All right. Thanks, Amy. Well, thanks for inviting me. Excited to be here and, privileged to be a part of AOMT overall, the organization that's done so much for my career overall. So, talk about yourself. That's always a challenging question overall, kind of on a spiritual journey as of late. So, labeling myself as this or that kind of thing kind of seems shallow and fake. But, just I'm a human being who's trying to be the best husband, father, physical therapist, professor that I can be. I've been on a long journey. I've just celebrated 30 years of being a physical therapist. So
Wow.
I've stayed clinically active for those whole 30 years and been in academia for 20 years and enjoyed my time at the University of Colorado and retired from there with a pension, which was pretty exciting. And now I'm teaching at a new hybrid program in Hawaii, which is just amazing overall. Our students are so diverse and hungry for knowledge and that type of thing. So it's been an interesting transition from brick and mortar to more of a hybrid education model, but I'm loving every minute of it, and I'm a firm believer in the approach overall. So,
Yeah. Yeah. That's great. And so you've been at Hawaii Pacific for how long? 2 years?
2 years, yeah, just celebrated 2 years, if you can believe that.
Wow. Well, what we decided to talk about today with you, and part of this was your choice, was patient expectations. I know personally, you and I have had many conversations about this, just because we both believe that it has such an incredible influence on what we're doing. And so, I'm going to kind of back us up, and I would just love to hear your thoughts on just explain to the listeners a little bit about what patient expectations are, I guess, from a definitional standpoint, and how they are really a critical piece in potentially influencing outcomes. So I just want to hear a little bit about what your thoughts are.
Yeah, so patient expectations are kind of the beliefs and anticipated benefits that patients have regarding the interaction that they have with their healthcare provider, the outcomes, the quality of care they might receive. So when patients have positive expectations, they're more likely to engage actively in their therapy. It can help reduce their pain overall. They're more likely to be adherent to their home program, and there's pretty good evidence that it can improve their pain and their function in the long run. So really, the patient's expectations are framed by a lot of different things overall, but they're such a powerful part of the treatment, especially in physical therapy,
Yeah.
that if we don't pay attention to them, we're missing a huge part of the therapeutic alliance and the care package.
And you were saying just a moment ago that there's multiple things that feed into patient expectation. So based on your many years in clinical practice, what do you think are some of those elements or influences that are going to influence what patients are actually expecting when they come to us for physical therapy or manual therapy care?
Well, the important thing is to remember that every patient is a human being with this complex milieu of past experiences and education, what they believe about themselves and others, what they've heard from their family, their friends, and Dr. Google and that type of thing. it's also strongly correlated with their worldview. Are they optimistic by nature? Are they pessimistic by nature? So the interesting thing is that these expectations that the patients come in with, which again can come from many different avenues, those can be changed by a positive healthcare interaction, forming a good therapeutic alliance with your patient and that type of thing. So you never know what's in the soup of that individual, what led to those expectations. It could have been something they heard or something they read or something they experienced. But really exploring that, I think, is a key part of what we do as healthcare providers.
And so, with that being said, what are some of those key things that you think we need to do from like the moment we start interacting with that patient, that human? What are some of the first couple of things that you're going to do to try to glean how to meet them where they're at in terms of expectations?
Well, the first thing, I mean, I love Peter O'Sullivan's, tell me your story. Kind of just listen to the patient and where they've been and the journey they've been on since this condition came on. It may be something that just started 2 days ago, or it may be something they've been dealing with for decades overall. So just listening to that patient and being present for them, really tuning in and kind of letting them tell their story. The research is pretty clear that in most healthcare interactions, the patient is interrupted before they get to complete their opening statement. So, hear what they have to say, and that helps you start to understand what their expectations might be. If they come in and say, "Well, I saw this provider and they told me this, and I saw this provider and they told me that, nothing's been working," you can kind of really start to hear the frustration and being able to empathize with that individual. That's really where it starts overall. And then I'll ask them, what are your expectations from treatment? What are your specific goals, patient centered? What do you want to be able to do? What are you not able to do now, and what do you want to be able to do? And then asking them what they think is going on. Maybe they've heard five different stories from five different providers, and maybe they have a set idea of what they think is going on, or maybe they have no idea and they're looking to you for guidance overall. So really exploring those expectations, and again, it's based on their past experiences. And then if things emerge that are in your opinion potentially detrimental to the improvement of the individual, that's where you could start to use some of the motivational interviewing things and say, is it okay if I share with you some information about back pain or neck pain, or that belief or that type of thing?
Yeah, I had a conversation with students similar to what you're saying just the other day, and we were talking about one of the associated faculty used this word. Some of our patients have become medicalized. They bounced around between so many providers, and they've heard all these different kind of stories about why they are in pain or what they need to do next, or you're not going to get better unless you do this or this. And so we were talking in class about just those challenges of sometimes trying to undo a lot of what's been done for individuals that are kind of just moving through the system, and then you see harmful things on social media on top of it. So what are some of your thoughts or strategies? Like, how do you undo the things that have negatively influenced patients and change their expectation for what they might get out of care with you?
Yeah, as you and I know, that is one of the most challenging patients to treat, is the one that comes in and says, my chiropractor or my physical therapist told me my sacrum is out or my L5 is out and I need you to put it back in. And they've got
Or
this
they're L6.
L6, yeah. Yeah, and those patients are really challenging because they had a previous experience where maybe it was positive. Maybe they did see a physical therapist or a chiropractor who did a manipulation and they heard a pop, and all of a sudden they felt better and they were back, doing what they want to do, and they're bringing that expectation into the treatment. And those are the really challenging patients, I think, to treat, especially if they're fixated on I'm broken or I'm out of alignment and I need you to fix me and make me better. So, I really try and engage them with the current best evidence, try and hear where they're coming from, but also encourage an active approach that,
Yeah.
there's things that I can do, but the most important part of this relationship in your recovery is what you do.
Yep. Yep. And you mentioned Peter O'Sullivan earlier, and I followed a lot of his work in it, and he really does a beautiful job, I think, of dialing into in some of the things that he's published on cognitive functional therapy. Really having the patient learn and be active in the process. So I think that's also really important. What you talked about, using best evidence. So before we talk about like best evidence of what interventions and what the plan of care should look like for the patient, what is some of the current best evidence surrounding patient expectations? What does that look like right now?
Well, there's an overwhelming amount of evidence from both medicine and in physical therapy that if a patient has a positive expectation, whether that was influenced by the healthcare provider or not, that's going to impact their outcomes.
Hmm.
So really, some of Joel Bialowski's work where they used manipulation, let's say, and they said, this is a technique that we think will improve your back pain, or we think this is a technique that we don't know if it will help your back pain, or this is a technique that we think may make your back pain worse. The that framing to the patient actually impacted the outcome. So the evidence is pretty clear that if a patient has a positive or a negative expectation, and that's not modified, let's say on a negative side, a negative expectation, if that's not modified, their outcomes are not going to be as good as if you potentially change those expectations. And I hate to use the word manipulate their expectations, but that's really what we want to do. We want to sell the evidence that
Right.
this treatment will likely make you better, and kind of reframe the treatment that you're delivering, making sure you're very clear about it. And that's the challenging part a lot of times, but you have to kind of present to the patient, okay, this is what my exam showed me. And you need to stay away from saying you're out of alignment or you have bad posture,
Yeah.
all those words that harm, kind of thing, and say, this is what I found in my exam. This is what the current best evidence says about treating those findings. And we published a paper called The Healthcare Buffet, where you kind of present to your patient, well, evidence shows we could use some manual therapy, we could do some exercise, you could do some aerobic conditioning, those type of things. We could work on some pain science education. We could work on some relaxation techniques, and those would probably all benefit you. Are any of those of interest to you? And that whole, patient-centered care and shared decision making, you actually put the evidence in front of the patient and say, what aligns with kind of your world belief? What do you think would give you the best outcome? And then let them choose, and then you proceed together as a team.
Yeah. Yeah, I like that approach. I think it makes total sense, especially on the heels of kind of all this kind of contemporary and updated information that's coming out about patient-centered care and why that's so important. But I think it's hard, as at least you and I both educate entry-level students. I think it's hard for us to, help them see that you have to kind of lay out the options. It's not all on you, actually. It's got to be on the patient too. So how do you said there's evidence in certain regions that expectations can positive expectations anyway might drive outcomes in terms of like a manual therapy intervention. How do you measure that type of a thing? So for those listeners that aren't necessarily as familiar with it, what does expectation research look like? What are you actually measuring?
Yeah, we asked the patient their past experience with certain treatments. We asked them specifically, do you think that exercise will help your condition? Do you think that manipulation or manual therapy will help your condition? Do you think that stretching would help your condition? And we give them kind of a Likert scale of when not likely or very likely, or those kind of things. And so we kind of assess their expectations prior to treatment, and
Yeah.
then we can look at whatever treatment they received in that research and see if their expectations correlated with the outcomes overall. And you and I have published a few things, and with Josh Cleland and Joel Bialowski and Mark Bishop, we've published on neck pain and back pain and shoulder pain, and there's probably a few that I'm missing overall. But
Yeah.
comes in with the expectation that the treatment that they're going to receive will help them, their outcomes are better. And the other thing I wanted to talk about with you is, you get these patients in these studies and they know that it's a manual therapy study. Maybe it's a randomized controlled trial. And the randomization occurs, and we open the envelope and we say, you're in the exercise group or you're in the control group. You can see them, the ones that have this really high expectation that manual therapy is going to help, they kind of deflate a little bit, like, no,
Yep.
and there are healthcare seekers and that kind of thing that will actually look for studies that where they can get the treatment that they really strongly believe in and that type of thing. But clinical research is really hard to be able to take a naive patient and deliver two different types of treatment to see which one is superior, because these patient expectations, every patient coming in has some thought or belief about what they're going to receive and what they think will help them, and if it doesn't match what they think will help them, their outcomes are not going to be as good.
Yeah. Yeah. It's interesting. I think that's the perfect example of when we see it, because our hands are tied and we're forced to be prescriptive because we're in a clinical research environment. But what's amazing is you get to the clinic and you actually get to tell the patient, these are all the options. Like you were saying, what did you call it? A healthcare buffet?
Yeah, healthcare buffet. Like you go to an Asian restaurant or something, and there's all this stuff that you can choose from, right?
Yeah.
And some you like, some you don't like.
Yeah.
So
But I like that analogy because in the clinic it's just different, and the patients can choose or prioritize what they want to do if you're kind of exercising that shared decision making model. Um, so you talked a little bit about some of the studies that were done in the past, and that was, I think it was interesting. I remember when you and I were kind of looking at the patient expectation information from the lumbar spine and the neck and the shoulder, all those figures looked very much the same. So do you think that's fair to say that you would probably see the same patient expectations in terms of influencing outcomes in other regions like the foot and ankle and the knee and across orthopedic conditions?
yeah, I think there's very few exceptions to the studies that have explored expectations where if a patient had a positive expectation for that treatment and they received that treatment, that the outcomes were not better compared to the
Yeah.
alternative. We've seen it in other conditions as well: headaches, migraines, irritable bowel syndrome, all kinds of different medical treatments, that type of thing. Um, and as I said before, the interesting thing about those patient expectations is you can mold those. The patient can come in and they can maybe have a neutral or a negative expectation about a treatment, but through a good therapeutic alliance where you really connect with that patient, get to know them as a human being, know that you're in this as a team, can share the evidence with them and say, the research shows this intervention would probably help you. What are your thoughts on that? You can actually change their expectations. And when you do change their expectations, their outcomes improve. So,
Yeah, yeah. So I have a question. It's related, but on a slightly different topic. There's a lot of information that's come out about placebo and nocebo, and patients might have an expectation. Oh gosh, there's that little thumbs up thing that I didn't mean for that to happen. Anyway, tell me how placebo effect and expectations kind of collide when it comes to clinical practice, or even what does some of the research say about placebo and expectations? What does that even mean?
yeah. So, placebo effect. Well, placebo is a supposedly inactive treatment. That could be a pill with sugar in it, or it could be a sham manipulation or something like that. The placebo effect is what happens, the physiological or psychological changes in a patient's condition resulting from the belief that they're receiving an effective treatment. So even if that treatment has no therapeutic value. So patient expectations are a part of placebo, but they're not all of it overall. So
Mhm.
so you can change a patient's expectation and improve potentially the placebo effect. But a lot of people get confused on placebo versus control and that type of thing. So a placebo can be a control. You
Mhm.
can have a no treatment control where patients don't receive any treatment. But the kind of the state of the art in medicine is to compare the active treatment to a similar treatment that the patient thinks is going to benefit them overall, whether it actually has some therapeutic value or not. And then we know that the placebo effect is around 30 to 35%
Yeah.
if patients think that they are actively receiving a treatment or doing something that will make them better, that we will see improvements in that. So the bar is really, does the treatment that you're investigating exceed that bar of 30 to 35%, will improve with the placebo, and to actually show that it made a significant difference.
So it almost seems like you'd have to have if we're getting granular, you'd have to have your experimental group, a sham group, and then a true control where nothing is happening in order to maybe sort that out.
Yeah, because natural history is such a powerful thing. Patients, even in patients with chronic pain overall, there is an ebb and a flow to it, and kind of a natural history overall. So you really, it is nice, like in our study where we looked at thoracic manipulation for patients with cervicogenic headaches. We had those patients come in, we did the baseline data. The ones that got the control got no treatment for
Yeah.
4 weeks, and
Yeah.
they stayed the same,
Yeah.
right?
Yeah.
And they'd had headaches, I think, what, for an average of 5 years?
10. Our average was 10 and a half years, which
Ten
was
and a half years of headaches.
like,
And so the group that got the control, which was no treatment, they just sat idle for 4 weeks, but it was a crossover study. So we wanted to deliver the thoracic manipulation to one group while the other group sat on the sidelines. And then after 4 weeks, they entered the game. We did the thoracic manipulation, and the improvements almost exactly mirrored each other overall. So that kind of proves that what we did in the intervention made a difference in these patients who had had symptoms for 10 years. And we had that control group where no treatment was delivered, and they didn't change at all. So
yeah. Yeah. And I'm wondering, things like that, it's hard to know how much natural history for something that's been occurring in an individual for 10 years as opposed to 2 months is also probably going to look different. It just occurred to me, Paul, that we actually gathered patient expectation data, but we never did anything with it. So maybe this was the impetus for us to do a secondary analysis of some of that data for individuals with cervicogenic headache.
yeah, yeah.
Um, so what are some of the thoughts you have on, like, I would love for you to share with people what is the language that you would use if someone has a negative expectation? So I'm talking about that patient that comes in and they're like, my brother, went to PT, it wasn't helpful. I'm not even sure if this is going to help, but I can't get, an injection until I do 6 weeks of physical therapy, or I can't do this or that, or I don't know. I have my own ideas, but I want to hear your thoughts. How do you realign those? What are the words that you use?
Well,
What
that's challenging, and it's
negative
individual.
expectations?
Every patient is different. Like in the situation with the brother, had a bad experience. Maybe explore that a little bit more.
Mhm.
But maybe there was some other variable in there that affected the outcome overall. But really, I try and bring it back to the patient. This is your life. This is your experience. This is what the current best evidence says. This is what my uh, expert clinical judgment says would probably benefit you overall. And if you bring that negative expectation into this therapeutic relationship, it will impact your outcomes. So
Yeah.
I'll give them papers. I'll let them read papers. I'll send them to websites that I trust where they can explore the intervention that we're talking about. That maybe we can start to reshape that expectation from their brother's bad experience or whatever, and
Yeah.
bring them around to maybe a more neutral or more positive type of an expectation overall. But again, you have to value the patient's experience, but you have to bring it back to them. This is your life. This is your story. This is what I think will help you. And then if you can change that, I think you can bring them around to that position.
So for some of our listeners that are maybe a little bit earlier in their education or training, would you say this is something that you're constantly and dynamically doing throughout your interactions, or do you believe you kind of deliver a little bit of bolus of information in the beginning in terms of trying to change expectations?
Yeah, that's a good question. That really gets into our bias, right? A lot of us are strongly opinionated about what we do and why we do it, and look at social media and all the manual therapy, love it or hate it kind of things overall. So we do have to present it in an unbiased fashion and not try to persuade patients or talk them into a treatment that maybe they are not interested in overall. But it is challenging, but trying to just present it in a factual basis, and then really involve the patient and listen to them. What are your thoughts on this?
Mhm.
Then we'll say, manipulation is a prime example. Cervical manipulation. Well, my cousin's sister's brother got manipulated by a chiropractor and had a stroke and crashed into a ditch and things like that. That's probably a patient that you're not going to bring around to letting you do a cervical manipulation on them overall. So there are some barriers to expectation, I would say, overall. But in general, if you can start to reframe whatever their expectation is, if it's on that negative side, you can bring them around. But if you can't, then move on to something else.
Yeah. And so, how are you, in the context of being an entry level educator, how are you kind of sprinkling some of this content in with your students? How are you helping them to understand that this is another component of how we need to interact with our patients?
Yeah. So, um, I really emphasize that therapeutic alliance with patients and being present for your patients. Most of our students, when they're sitting in front of a patient, they've got their heads going in 1,000 different directions. They've got a checklist in front of them. They don't even make eye contact with the patient.
Yeah.
Or they've got their tablet or their computer up and they're documenting while the patient is talking. And I really try to get them out of that mode where they can be with that other human being, look them in the eye, talk to them. And I've always told my students, you've heard me say this, that your interaction may outweigh your intervention, right? I
Yeah.
mean, we've got all these studies that show that manual therapy helps maybe a little bit in the short term. But if you look that patient in the eye, get to know them as a human being, really invest in them as a healthcare provider, that will likely have a better effect on the outcome of your treatment than any treatment we can throw at our patients overall.
Yeah. Yeah. And I think it's exciting to see that, there's work being done now to really try to figure out how to better harness that shared contextual piece. It's not all about, it's interesting because I hope we're starting to move away from the fact that we think all of our interventions, whether it's manual therapy or exercise, are what drive the outcomes. It's so much bigger than that, including, our topic here today of expectations, but also of some of these shared mechanisms. So I think it'll be interesting to see what more we learn about how that really needs to be a big player in the intervention outside of just, exercise and manual therapy, for example.
Yeah.
What are some things that are kind of, I don't know, when you've done lectures, I know, in various places and in Europe on patient expectations. What are some of the biggest things that your audience tends to be curious about, or what are some of the things that maybe continue to um, interest you about this topic, or what are some things that surprise you maybe about this topic?
Well, I think the big thing is just not paying attention to the fact that patients have expectations and that
Yeah.
you can explore those and that you could potentially modify those expectations. I mean, that was eye opening to a lot of people that I give this talk to, and they say, "Well, isn't that deceptive if you tell them, this manipulation will make you feel better?" If you're sharing current best evidence and you can back it up with research, then it's not deceptive at all. And then harnessing the placebo effect. I openly embrace the placebo effect in physical therapy. I think it's a huge component of what we do, whether it's manual therapy or exercise. And I will tell patients that. I mean, the new research out on open label placebo, where you tell the patient, I mean, there's one great study on chronic low back pain, who these individuals had pain for, I think, 5 years at a minimum, and they gave them a placebo and they said there's no active substance in this pill. But in research studies, it has shown that people who take this pill have an improvement in their pain and their function and that type of thing. So they're very open about the fact that this is a placebo, and they saw significant improvements in those individuals and they tracked them out to 5 years, and that was maintained out to 5 years. And at the end of the study, when they stopped giving them the placebo, a lot of these patients would say, where can I get a prescription for that? Where can I buy that? And you tell them it's just a sugar pill, right? There's nothing in it, but they want to keep taking it. And there's something about that, doing something active for your health. Maybe when they're taking that pill, they're thinking, well, maybe I should walk a little bit more today, or maybe I should eat a little bit better today, or maybe I should get more sleep. They take a more active role in their recovery just because they're doing something they think has potential therapeutic value overall. So I
Wow.
tell my patients that there may be a placebo effect in this, but we know that the placebo effect is very powerful. It's getting your brain on board with this plan of care that we're going to be doing, and that will improve your outcomes.
Wow. So you're saying maybe it boils down to like the ritual of taking a pill and maybe something that's happening in the present when they're doing that?
Yeah. Yeah. I mean,
Wow.
just the fact that the patient every day is taking that pill, because that was key in that placebo study, that open label placebo, and they've done it near irritable bowel syndrome too. Exact same thing, where they told the patient, you have to take this every day, and you have to document that and that type of thing. So the ritual of doing something every day that may help with their back pain or their irritable bowel syndrome and that kind of thing, I think just shifts their mindset overall, that, hey, maybe I'm not going to eat that cheeseburger for lunch. Maybe I'll get a salad, or maybe I'll go for a walk instead
Yeah.
of sitting on my phone on social media for the entire hour overall. So
Yeah, I think that that research is so interesting. And I think it's important for us to think about that component too, that some of what we're doing is probably tapping into placebo. So what do you do? I love the scenarios of, like, you get a patient that comes in the clinic and they're dead set on the fact that ultrasound is going to help their neck pain. I mean, I've seen those patients, and you have to, how do you kind of rectify that disconnect between, it actually kind of kills me to plug the machine in and actually do this, but yet the patient is saying that they're expecting that it's going to help. What's your response to that, and how do you manage that?
yeah, that's interesting. I remember I was talking to John Childs. This was like 20 years ago or so, and asked him that exact question. The patient comes in and said, last time I hurt my back, I had ultrasound and it really helped. And he said, do the ultrasound.
Yeah.
And, that's their expectation. And I've tried the contrary, where I'll say, the evidence shows that ultrasound is not very beneficial for back pain, probably won't help you a whole lot. And then that creates a little bit of adversarial relationship between
Yeah,
the
agree.
patient. This is my experience, this helped me, and you're telling me that you're not going to do it because there's not a study that shows that it helped me,
Yeah.
right?
Yeah.
So I will embrace those things. I may share a little bit of knowledge about the benefit of ultrasound, but the other important thing is, while you're doing that ultrasound, you can be educating the
Yeah,
patient. You can
that's
do
right.
some science education, or you can talk to them about activity modification, or reinforcing their home exercise program, or the overall plan of care and that kind of thing. So it's not really wasted time, and who knows, maybe it does help them. So I try not to poo poo too much on patients' positive expectations. If something in the past helped them, by all means, unless it was something harmful to their health, that drinking too much, or using drugs or things like that, opioids, that kind of thing. That's a different discussion overall. But if it's something that has no potential harm overall, then I fully embrace that.
Yeah, and I think what's also hard for us to swallow sometimes, I've had experiences where patients absolutely 100% have the expectation that they should have or move forward with a surgery, that I don't believe they necessarily have objective findings to support the need for that. But I'm telling you, it's hard to talk a patient out of a surgery that they're convinced that they need to have. So I believe that's another avenue where I tread lightly. I present information and research, but surrounding what some of the outcomes are with some of these orthopedic surgeries. How do you handle that?
Well, a lot of those situations are driven by the surgeon, where it's not just the patient who absolutely believes it. The surgeon has told them they absolutely need this surgery to get back to function, and that's where we can present. Let's take lumbar stenosis for example. The main stenosis study that tracked patients out 10 years who had surgery, lumbar fusion versus not, and they looked exactly the same out to 10 years. You can present some of that information to patients. Now, if there's a clear indication for surgery, they've got progressive neurologic deficits, or spondylolisthesis that's unstable or something like that, that's a different story overall. But
Yeah.
that is where I will try to, counteract what they may have heard from another provider. Well, that provider told you absolutely need this surgery to get back to what you need to do. I'm telling you from personal experience, I've seen patients just like you who have gotten back without doing that surgery.
Yeah.
So I tell them, give me 6 weeks. Give me 6 weeks. And if you're not where you want to be in 6 weeks, after I've done all the patient education and maybe some manipulation of their expectations, if you're not where you want to be in 6 weeks, by all means, you can go get that surgery.
Yeah. Yeah. So from the clinical perspective, because I know you treat weekly up at Wardenberg at University of Colorado in their student health center, do you capture any patient expectation material or through through, intake paperwork or anything like that? Or do you pretty much try to garner what their expectations are in that initial encounter?
Yeah, that's really challenging. I mean, patients get form fatigue, right? They have to fill
Right.
out so much paperwork at their
Yeah.
initial appointment that we don't routinely assess for expectations. But that's part of my subjective interview that I'll be asking them about it. What kind of treatment have you had? What do you think is going on with your back pain? What do you think will help with your back pain? Those type of things. So
Yeah.
do it more informally. It would be ideal if we could have a standardized. The other thing about the expectation literature is there's no one form. I mean, I looked at a systematic review where there were 19 different patient expectation forms. I
Is
mean,
that right?
which one do you use?
Right.
So again, I tend to do it more informally, but I do think you can glean a lot of information just from asking the patient.
Yeah. Okay. I've kind of two more questions, and then I'm just kind of eyeing those guitars behind you, and I don't know, I might try to twist your arm to play a little.
No, no, no.
All right, that'll be for another one.
Yeah.
So, what in terms of what's the future of expectation research? Like, are you kind of privy to what that next layer is now that we know that expectations can influence outcomes, especially with people with musculoskeletal pain? Is there anything on the horizon for us?
Well, I think the interesting thing will be pragmatic clinical trials where you kind of let the clinician explore expectations and then maybe make some suggestions to the patient and that kind of thing versus a more prescriptive kind of approach where you just deliver the treatment. I mean, that's been done to some extent, but really embracing that placebo effect. And then, potentially exploring, you know, the effect of placebo in physical therapy itself, because we hate to think that some or much of what we do is actually placebo effect, but it is. I mean, but going into that placebo effect again. That's you know the patient changes their thinking or their psychology or their physiology based on their expectations and their thoughts of what's going on. If we can change that overall, and Joel Bialowski's done a lot of really good work on that front. But I think just embracing the whole package, because we have all these studies coming out, let's say on back pain, that shows that there's no one clear exercise, specific versus global, or local versus global, and those kind of things. And the key thing that comes out of those research, and the same thing in manual therapy too, it doesn't matter the exercise or the technique, it's getting the patient doing, which goes back to that whole ritual thing, that they're actually doing something that may improve their health. Maybe that's the important thing. It doesn't matter how the movement system, people are going to hate this, but it doesn't matter how specific our movement analysis is in our exercise prescription, which is a whole nother
Yeah.
topic that PTs suck at. But maybe it's just getting the patient moving. What exercise will help you? What do you like to do? What can you do at home? So many times we prescribe exercises that the patient either can't do or is not interested in doing at home. So just embracing, what they will actually do. And that's where motivational interviewing can really come in. How likely are you to do this exercise program that we just talked about today, and kind of moving in that direction. So I'd like to see physical therapy research start to embrace all of these things and to include, therapeutic alliance and the patient expectations, as well as current best evidence on, exercise and manual therapy and those kind of things, and kind of look at the whole package together. And then the other thing that, you know, John Childs told me, we need to stop comparing one PT intervention to another PT intervention. We need to start comparing what we do as a profession from the initial, second that we interact with that patient until we end that episode of care. Compare that to what orthopedic surgeons do, or that kind of thing, and give them the whole package rather than just breaking it down and saying, oh wait, what does this manual technique do, or what does this stretch do, or what does this exercise do? Use the whole package and compare it to other standards of care for that condition to prove that our profession has a better answer in most situations to, the medical model, if you will.
Yeah, I couldn't agree with you more. And some of the, kind of details of what we're missing. And I know, I mean, you and I have been working with with a bigger group on a neck pain clinical practice guideline revision. And one of the things that we've struggled with as a group is no one's reporting dosing. They're doing manual therapy, but we don't know what it is because it's not well defined. But I love that idea of taking more of like a meta view, I guess, of what we're doing from beginning to end in, an episode of care, instead of trying to dial into these minutial details, because we don't have answers for dosing for exercise or manual therapy. We're actually doing we're lost. I think we don't, we think that manual therapy holds all this power, but we know that the multimodal approach is best, but we still don't know how much is the right amount. So I love that concept of maybe thinking about, looking at the forest and not so much being in the trees, and trying to figure out how we measure up to what's happening in other, avenues of healthcare.
Yeah, and that's what, if you haven't read any of Julie Fritz's most recent work, that she's kind of taken that 20,000 foot view. It
Yep.
doesn't matter, what you do in from treatment to treatment, what you do. It's kind of stepping back. Is it more of an active approach? Are you using, current best evidence? Are you educating the patient and that kind of thing, and looking at the whole package? Because what we do as physical therapists is not, manual therapy or exercise or this kind of thing. It's a whole package, which those soft skills are such a huge part of.
Yeah. And those are the things that I think as educators are the most challenging for us to figure out. It's kind of that affective domain of learning. How do we keep scaffolding that in to the curriculum, so our students really appreciate that as a skill set, and not just, their perceived need to develop psychomotor skills. Cause I think some of the other ones are equally, if not more important. And I think patient expectation is a part of that. Okay, so top two or three things that you, as we kind of wrap up our conversation, that you want our listeners to think about, whether they're educators or clinicians or students or residents or fellows in training. Give me like a top 2 to 3 things that you want people to walk away remembering.
Uh, well, I think just acknowledging that the person sitting in front of you is a human being that's bringing a lot of things to the table that you know nothing about. So exploring that a little bit and finding out, what they believe, what they think, what they've heard, those kind of things, and then trying to tailor your treatment approach to, that individual human being who's sitting in front of you. I
Mhm.
like to say to patients, the good news is you're in the right place. I see this a lot. Uh, there's current best evidence that shows that, we can make some improvements in this area overall, and just really involving them in the overall shared decision making, that type of thing, involving your patient in their plan of care overall, and then, moving forward with them as a team, rather than you being the dictator and saying, this is what we're going to do, and today we're going to do this, and that type of thing.
Yeah.
And then again, that therapeutic alliance, just getting to know who your patients are before you enter that relationship with them is so powerful. I mean, talking to them about their kids or their dog or things like that. I mean, that has such therapeutic value that we can't really put a finger on, but just having that interaction with the human being that's in front of you.
Yeah. Okay. What book are you currently reading?
um,
I didn't put that on the list, so sorry to spring that one on you.
yeah, yeah. I am reading this book called The Holographic Universe right now,
Ooh,
that kind
okay.
of explores spirituality and quantum physics at the same time. That, if we always hear we're all connected, right? Everything's connected. Well, on a physical level, at the quantum physics level, it's true. And so, it's just interesting to kind of explore that.
And how did you get there? How did you find that book? Was that a recommendation or?
Yeah, I think it was another book that I read that was kind of talking about, when you get down to that quantum level overall, how everything is connected, and the whole wave particle duality thing. Is it a wave? Is it a particle? As soon as you start to observe it, things change, which is what happens in our patients too. When you pay attention to them, things change overall. So.
Well, Paul, I just want to thank you on behalf of the AMPT organization and myself for taking the time to talk to us a little bit more about patient expectations. And I think why we value you as a member of AMPT and as an educator is you're in all of it. You're in the educational piece. You are in clinical practice. and you're doing research. And so I think listening to you, it just you so eloquently kind of weave all of this together because you're doing all those things concurrently, and I highly value that about you. So I appreciate hearing your insights and having you share a little bit more with us about this topic.
All right. Well, thanks. It's been a pleasure, Amy.
Okay, thank you.